Thank you very much for the kind introduction and invitation to come back to Paris, which is always a great pleasure. So I will take you into the ERN-CRANIO, the European Reference Network. And this was all started in 2017 when Europe decided to make 24 of these networks, all designed to take care of rare diseases or complex diseases. They designed by their own the 24 ERNs, and fortunately one of those was designated for craniofacial anomalies and ENT disorders. So this is the governance that we use. So we have three large work streams, one on craniofacial, and that's amongst others led by Eric Arnault. The work stream 2 is on cleft lip palate and odontological disorders, and there you will find Agnes involved. And workstream 3 for ENT disorders, and Nicolas is one of those. So here you see all the diseases that we cover. And of course there's overlap between ERNs. So for instance, you see neurofibromatosis is one of the disorders. We focus then mainly on the craniofacial presentation, but there's like 8 other ERNs in which neurofibromatosis is a included disease. So by now we have 48 hospitals out of 24 countries that are involved in ERN-CRANIO. We distinguish full members. That means that they have all the accreditation from their government themselves, but also all criteria that we have designed as a team. So that's 35 out of these hospitals. Affiliated members do not reach all criteria yet, so they can become full members in time, and those are 5 hospitals from 4 countries. We have Luxembourg and Malta, which are actually too small a country to have designated centers for rare diseases of all kinds, so they have entered all 24 ERNs as a hub. So they take part in all the discussions and know how to refer patients when needed. The nice thing is we also have supporting partners, because we lost the UK due to Brexit, which is a big loss, because there's a lot of expertise in those centers, but they've now re-entered as supporting partners. And also we have Greece, we have Switzerland, and even centers from the United States. Very important, we also have patient societies included and other associated societies like ESPO, so the European Society for Pediatric Otolaryngology, the European Society for Pediatric Neurosurgery, and so on. Recently we have new EPACs, so that's patient societies that got involved in our network, and that is, for instance, Les Petits Courageux from France, and even Bulgaria. So Bulgaria, we don't have a center there, but we have the patient society, and I think that's very important that we have this outreach to all the patients out there. Others are potentially joining, so that's I think the most difficult way to get those patient society really involved. They are all interested, but it's for them often hard to find the time. Language issues, there's several issues that makes it sometimes difficult, but we need to do everything we can to make life a bit more easy to get them on board. So as I said, 2 centers now have joined from the United States. It's Philadelphia and it's Pittsburgh. Both centers really wanted to join in our network. They have the expertise which make them very good partners, and we are happy to have them on board. We have a scientific committee, and as you can see also the chair is from local, it's from Paris here, it's Roman, and the scientific committee is increasingly important, because this is a number of the tasks that they have as a scientific committee. So for instance, all the new candidates that come forward and want to join our network, they need to be tested according to our set of recommendations that they have to fulfill our criteria. So that's what they do. But also, now we are building and creating all these data in our registry. We need to have a policy on who gets access to these data. So that's also an important task that the scientific committee is working on, to really judge who can get the access and how to deal with all the publications coming forward. So they review webinars, courses, publications in regard to the ERN accreditation. So if we think this is a course that's really important, it's of high quality, we will give it like the ERN-CRANIO stamp. And one of the first courses getting this accreditation is the monoblock course being held here in Paris next month. And of course, you get all this info straight away from the European Commission on new calls that are out there for joint research. And it's the task of the scientific committee to really get this going and engage all the partners in making joint calls. So this is how we do this, the accreditation of the courses. We don't invent the wheel. There is a society that is there, the European Accreditation Council. What we just do as an ERN, we point out that this is the way to go. We will pick up the bill to get this going, but of course this is part of the team that are doing this. Guidelines, I think that's a very important output. Guidelines are often there for the more general common diseases, because it's a lot of work, and of course that means also a lot of money involved. So we set out to make guidelines for all these rare conditions. And those are the ones that we already have, so it's on craniosynostosis. We made a patient version out of that so that it's easy readable for patients. We all publish them open access to make it very easy going for if you don't have all these prescriptions to these journals. And what we also offer is these patient versions, we can translate them to every language within Europe, because otherwise, if we just spread out only English version, that will not help patients throughout Europe. So whenever a country asks for us for a certain language, we will help you with doing that. There is a guideline on neurofibromatosis that was actually done by the ERN Genturis, which is an ERN focusing on genetic causes for cancer. But we collaborated in that one. Craniofacial microsomia, and just recently Robin sequence was developed. A consensus statement will be out there very soon on facial dysostosis. So that means Treacher-Collins, Nager, and Miller syndrome. The difference between a consensus statement is that it is of a somewhat lower level of evidence, because these conditions are so rare that there's not a much of high-level publications out there. So then it's considered unsuitable to make a guideline, and you go for a consensus statement in which all the centers, including patient representatives, agree on the conclusions and the recommendations that are given. You can always find all these guidelines, by the way, on the ERN website if you are interested. We try to make as much as animations and webinars as we can, and we have those animations made for healthcare providers themselves, but also for patients. So a number of videos and animations are here now mentioned, but there's much more. And we have our own YouTube channel, again, to make them very commonly and easily accessible for everyone. So visit our YouTube channel to find all these animations. And I think they are really nice, and some of them are really made in collaboration with patients, so that we really address their needs and their level of understanding. So that particularly goes for surgical procedures. We don't make animations for any surgeon out there, so this is how you do it and give it a go, but it's really to explain in simple, unbloody pictures how surgery works. Nice thing to know is we have exchange programs, both for researchers and for clinicians. And that's really nice. If you want to spend some time in a certain center to either bring your knowledge to that center or to learn from them, just apply for these exchange programs. They're very easily available. Just send us an email, and we'll try to hook you up to the team that you're interested in. and especially also in these clinician exchanges, it is much more common for us as medical specialties to go on an exchange because you know them well and it's easygoing. But it is as valuable for our OR nurses, our nurse specialists, fellows, everyone else to also go on these exchanges. So we just recently have had the speech pathologist from Padua at our center, and that is really fabulous. You learn a lot from each other. So please take note of these options that we have and make use of it. These are some examples. Most were very happy, and it includes Giovanna on the picture. And I think that, as I mentioned before, the nice thing about our ERN is that it includes all sorts of specialties. So you have other ERNs that focus mainly on, for instance, vascular surgeons or urologists, and then you get to know each other, but you already know each other. It doesn't add value. I think there's not much conferences or meetings where you encounter the ENT surgeon or the pediatrician that also is involved in taking care of the same diagnosis. And that's really valuable in this ERN. So we have these working groups on a certain diagnosis, but we make sure that it is involving all the specialties that take care of these patients. So we have a special group that really takes care of the interaction between patient and the clinicians, but the nurse specialists, because they really learn a lot from each other by exchanging knowledge. The OR nurses, the geneticists, the psychologists are there, but also, for instance, radiologists. That was a really interesting meeting that we have with radiologists to find out how different the protocols are between the centers. You just assume that your center and the way you're doing CT scans and MRI scans, that is the normal standard. But there's a lot of discrepancies out there, and it's really interesting to find out how this works. The last group is just getting started on disturbed breathing and sleeping, so I think that's also a really nice and promising group. Just to give you an idea of what kind of research projects that we also started within the group on craniosynostosis, and that's, for instance, on how do we manage the airway straight after surgery when we performed mid-phase advancement, so mainly the monoblock or LaFour-3. And that is also a big discrepancy among centers, and I'll show you a little bit of the results in a bit. We're now working on tonsillar herniation and syrinx in croissants, and how to work with 3D photos, because that's a relatively new imaging technique. And everyone is designing their own workflow and their own pipelines, which is a shame, because that hampers the exchange of knowledge. So if we standardize how you take the photos, how you analyze it, that will help us a lot. So this is the study that we did. 7 centers were included. And I think this is an impressive number of cases. So we had 275 croissant, Pfeiffer, or APER patients. No single center will collect these kind of numbers. So it included 129 monoblocks, 147 LaFours, and we just asked these centers, retrospectively, of course, what did your anesthesiologist do directly after you finished surgery? So there were 4 options, either immediate extubation, delayed extubation, and delayed was everything longer than a few hours, a short-term tracheostomy, just designed and inserted for this surgery, or the child had a long-term tracheostomy anyhow. These are the slides of 275. If you see, the highest number is a delayed extubation, the DEX. 162 were delayed in the extubation. While there was not a big discrepancy with the degree of sleep apnea that they had, so that was not the major reason for the delayed extubation. And if you then look at the 7 centers individually, you see that green is the most often used, the delayed extubation. And there's actually just 2 centers with a large blue column, which is immediate extubation after surgery. And then it's, of course, interesting, how well do these patients do if you compare immediate versus delayed extubation? There is no difference in the short-term support that they need after the extubation. It's either nothing or just a few hours or a day of some extra oxygen. That's it. So in red is re-intubation, hardly occurs. So that's interesting. There is actually no reason to keep these patients all intubated, which means longer stay on the ICU. But also it means more risk of getting pneumonia. So that is a really big difference, that you see that 15% of the delayed extubated patients got a pneumonia and none of the immediate extubation. So we know it's safe, you don't need to be re-intubated, and the risk of getting a pneumonia is much less. So why not aim for immediate extubation? And I think no single suture would have proven this, because you are stuck in the protocol that you are used to, that your anesthesiologist adheres to, which makes sense, but it's nice to do this kind of very clinical studies and to see what others are doing and how safe or not it is. So another project that we've picked up on is the Orphanet codes. That is, of course, very relevant, because if you go to ICD-10 or ICD-11, then you will just find one code for nearly all craniofacial disorders, so that doesn't help you. So you need to be really granulate. You need the Orphanet codes. But most of these codes were rather outdated, and all the new genetic studies were not implemented yet. So we started a working group, and we participated with Orphanet to re-examine all these codes, and of course a review of the literature. And it takes a long time. We started in 2019, started working several sessions, going back and forth, including our geneticists from various centers to make sure that we all agree on this. And we're now just finished it. So it's now being completed. And I think that, but that's just craniosynostosis. So there's other cohorts of diagnosis that you can still have another look. And does it make sense how it is right now, and does it need an update? So that's an ongoing process. And of course you need to implement them. That makes life easy when you start searching for your patient in your own files, but also if you want to enter data in our registry. So we need to implement these ORPHA codes in every hospital that is part of our network. And that brings us to our ERN-CRANIO registry. Every ERN got funded by the EU to develop their own registry. And it's a bit of a shame that it was so like, you're on your own, please take care of this, because that hampers the exchange of data, of course, in a bit. We made the decision to go to Molgenis, which is a platform that's hosted by the University of Groningen. And they host in total 5 of these ERNs. So that's nice, because the other ones that are there are by heart Skin, Genturis, it's us, it's Ithaca, and I think Ithaca is especially very relevant, because that's the ERN on mental disorders, genetically based. So there's a lot of overlap with our patients. And they're all at the same platform, so we can easily exchange data with them, which makes a lot of sense. So this is what we intend to do. We want to pool together all these data from the various hospitals to really allow us to do much better research and better studies. So that means that you have to decide what kind of data do you want to collect. So there is like a base set that the EU wants from us, and that's quite simple. It's very straightforward type of data that doesn't tell you a lot. So we are most interested in getting outcome data, because that will make these comparative studies quite interesting. Like if everyone has their own treatment protocol, which differs, you can make comparative studies on outcome. How relevant is it? And who has the best outcome? then we want to know how you got there, what you do, and we should all be trying to implement those good aspects. So for these disorders, we are making or already made an outcome set based on consensus. So it were the experts themselves who decided, okay, this is what we want. We have consensus on the type of outcome measurement, when to do it, and how to do it. And for instance, this is what we do for sagittal synostosis. Every age we decide what to do and how to measure it by consensus. The registry is more than just putting in data. Of course, you need to make it really attractive. So you need to make a dashboard so that you get feedback, that you know what is now in the registry. My own data, the data of the entire network. So the data sets for all the diseases. We have just a few included, but all these other diagnoses, they need data sets as well. Of course, there's a lot of legal issues, so that's what we mean with the DIPA and the data access policy. So make sure that we stick to all the legal stuff within Europe, so that we have all these contracts between countries and the EU, and make sure that everything is safe and that the patients have consented for the inclusion of their data, that they can always retract their data whenever they want. So this is all work in progress. I think for the ERN we're now almost halfway with the number of signed contracts for the legal issues. So we're like not way ahead, but a bit ahead of the mean. So this is, for instance, how the landing page looks like. Of course, these were developed with fake data, because at that time it was just having a feel on how it looks and if this is what people want from the registry. We can easily adapt that ourselves. So once it's going to be activated, we can always have feedback from the users and make adaptations. And it's not only the general data, it's also specific for each center, so you can see how you are doing and how you benchmark across the overall ERN registry. And of course, per disease, which is very relevant. We just got a new grant, because as I said, we started in 2017. In the beginning, it was 5 years period that we were allowed to start. And in the beginning, it was not a lot of money that we got, and we had to pay a lot of it by ourselves. But because it's so successful, the EU has put a lot more money now into it. And now we're giving a grant until 2027, so that's nice. And these are all the plans that we have for those years. And I think that most make a lot of sense, but perhaps FaceMe is not known by everyone. FaceMe was a very out-of-the-box project. So we had the feeling as a group, like there's a lot that we try to do for patients, with patients, but is it enough? Is it enough that we write brochures, make webinars? It doesn't feel like that is the entire package, what a patient has to deal with. They go out every day being confronted with a different look, being confronted by other people surrounding them, asking questions, being rude sometimes, or staring at them. So this is why we asked a couple of artists, what would you do if you hear this issue, and go and talk to a lot of patients out there and come up with an idea? And I think they came up with a rather brilliant idea. And that's why you need perhaps to be an artist, to be completely out of the box. And what they said, well, actually what we hear is that for instance, as a parent, you hand over your child to a surgeon that you have to trust, and I actually don't know why do you trust that person. You don't know each other quite well, but you hand over your child, your most precious belonging that you have. And he's going to change the face, the skull of your child, and it's going to be for the better, we assume, is what the artist said. But that's major. That's a major life event for those parents. Why not change roles and make you experience what it is that they experience? So what they asked me, would it be okay if we bring on patients and other doctors into your home, and at that single time, just when they come in, they were not briefed beforehand, they are given the trust to completely redecorate your home. And they can go into every cupboard, every drawer can be taken, can be opened, everything is allowed. And I said, well, yes, if I'm allowed by these parents to do surgery on their child, why not turn places and give them this confidence? And it was really, really impressive. That entire day, at the beginning, these patients and parents were like, also like, oh my God, I'm so afraid that I'll break stuff. And I think, yeah, that's exactly the feeling that we can have on the OR. I don't want to make injuries to the child or create complications. And it was really terrific. So at the end of the day, it was unclear who was patient, who was a doctor, and we really understood each other much better. They made a movie out of this. It's a 12-minute movie. It's on our website. If you're intrigued by this, go and have a look. We're so happy with these artists that they will continue this art project and probably will be going to the team here in Paris. And of course do something completely different, because this has now been done, so they're now designing a new topic. But all looking at the position of the patient and how can we really, well, not even help the patient, just create understanding amongst each other. So I think that was going to be really, really cool. Goals that we set out is, of course, we need in the coordination, in the dissemination of our knowledge, and we need to evaluate all these programs. That's all what the European Commission asks of us. CPMS is also being just launched. CPMS is a system in which any doctor anywhere in Europe can upload everything on his patient, like pathology, slides, MRI scans, you name it. It's a safe environment, and he can just pick people from the network that he wants the expertise of. So if you want a consultation on a very rare case, you just select the experts, and then you can communicate about this, this patient. The initial version was not great of CPMS, so they now launched a new version which should be much better. So we look forward to that as well. We'll put a lot of effort, of course, in the ERN registry. That will open up a lot of research opportunities. So that's also nice. Think ahead of what is your main question for research that you want answered, and go to the scientific committee. Clinical exchanges keep going on throughout the project. And the guidelines, of course. Besides specific activities within our own ERN, we also have like overarching projects involving all 24 ERNs. These two are just recently started. So that is the ERDERA, that's an alliance. That's just, actually it's additional money that European Union gives to us to really push forward the ERNs. So for instance, we are into this project looking at how to extract data from electronic patient files in a much more sensible way, and how can we speed up these kind of developments throughout all ERNs, because that will be as interesting as well, of course. Comparing your data with other ERNs in which our patients are also involved, such as Ithaca. So this is a nice boost for all ERNs collaborating together. And we now have the Jardin project. That's a joint action in which all of, particularly the board of member states, so the health governance people involved in the ERNs, are taking the lead, and they really want to work on how to integrate all these pathways that there are for patients within your national governance. So I think for France, it's pretty good developed. You have all these levels of expertise, so usually a patient will get into that flow and end up at the right center of expertise. Many other European countries do not have this. So they need to be working on their workflow as well for patients so that they end up at the right center where they get the right treatment. And if it's not in their country, then they should be moved to another country where it is available. Because that is the nice thing about Europe, that there is this law that says if it's unavailable, this really expertise care for your child or yourself, you are allowed to go to another country in Europe to get this care. So these are two overarching actions that are just starting. And then finally, we have every year a meeting in which we come together, because it's nice, all these Zooms and other ways of digital meetings, but in the end, meeting each other face to face has a lot of extra value, and we try to go to every other country within Europe. So this time, Poland is the one that we go to, and it's Gdansk, where we will meet in the beginning of November. It is for members only, but it is, in each meeting, we have a lot of expertise that we share and that we also make webinars out of and that we put on our website. So again, it's not inner circle, we try to share all the advantages that we book down there. So I hope to give you a good overview of what we all do in the ERN. It's a lot, but I think it's so nice that we as doctors or other care providers and patients and researchers, we're all in the driver's seat. So no one is telling us especially what you need to do. They just facilitate us, they give us a fair amount of money, and it's up to us to make it work. So that's the really nice thing of this project. Thanks for your attention.
Thank you very much again, Irene.
Thank you.
Do you have any questions in the audience? We don't have online.
Thank you very much for that great presentation. I have a couple questions. First, how do you consent these patients for data sharing? And the second question is, when you have a data use request, is there a committee that where you review the request and then whether you decide to grant or not grant the data?
There is a consent form that's designed by the European Committee, so that ticks all the boxes legally. It's available in every European language, so it is up to all the centers themselves to ask permission from the patient to enter the data in the registry. There are other ways as well, but that's for every nation is different. For instance, in our case, we asked a opt-out system and asked if it's patients that we don't see annually anymore, so they're older, we see them like once every 5 years. Is it okay that we assume that they will join, but they're always given the opportunity to withdraw? And that's by our ethical committee allowed. But these kind of exceptions, you need to go through your medical ethical committee for every single country. And your second question was, is there a committee? Yes, we have the scientific committee who designs the policy on who gets access. So in principle, if you're a full member, you will get access. But if you're a full member for instance, craniosynostosis, you cannot say, oh, hand me over all the data on cleft lip and palate. That doesn't make sense. So you should be involved in the data that you are interested in.
What about people who are not part of the membership?
I think at present we're reluctant to do that. Okay. It could be in a collaboration. So it's like the UK. They're now not full member anymore. So we feel it's strange. They don't enter data. It's strange if they could pool all our data. But if it's done in collaboration with full members, it's an option.
Thank you.
It's extremely nice to see and to hear that progresses have been made. It took some time, but yes,
it
it's
took time.
significant progresses have been made.
Yeah.
Other questions? Yes.
Thanks a lot, very interesting. I have a question about the experience that you explained when you invited patients to come into your place and change everything. So I'm curious to know, what did they change and how did you react and what did you learn from this experience? Which is quite interesting, actually. Yeah?
It is. Well, it is quite interesting to say, first, it was very clear that they were quite hesitant and reluctant and felt, oh, this cannot be true. And they said, are we really allowed to do this? And then slowly they got more confident and they really got going. So we did 2 projects that day. One was taking over my bathroom, and it was completely changed. And it was like the fun bit. There were a lot of laughing and it was just fun. And then that finished, and then the artist said, okay, now we're doing the living room. And imagine more as if it's surgery that you're doing. And that completely flipped their position. So all of a sudden, it wasn't great fun and laughing, but there was a plan. They collaborated with each other. Let's do this, let's do that. And it ended in a completely symmetrical position of everything. It was really weird to see how pretend that it's surgery completely flipped their state of mind. And I think that the remarks that you get afterwards from these patients, those are very valuable. So there were remarks like the trust that we gave initially when our child was operated was now returned, and comments like that. So that's it was very special.
But how did you experience that?
The
changed.
Everything was changed. I was quite okay with that because I think that's only stuff. So it could be that something gets broken, but I'm quite aware of the risks that we take doing surgery on a child, and then it's not, it's just broken and I'll get a new one. So I was quite aware that I was actually on the lucky side by doing this. But the most common remark that I got from all the colleagues that viewed this movie said, I would never do this. It's so intimate, it's so personal, and that was not my feeling. I really liked it a lot. It was special. Yeah. Well, thanks very much.
Thank you. Thanks to you.